Welcome to the Hospital Medicine Unplugged podcast. Today we are taking a critical, in-depth look at acute pericarditis. It's a condition that might seem straightforward on the surface, but it really carries high stakes in the inpatient setting. We need to go beyond just the classic textbook description, don't you think, and focus on the immediate priorities. Symptom control, sharp risk stratification, and preventing those really disastrous complications like recurrence, progression to tamponade, or even eventual constriction.
That's absolutely the core challenge, isn't it? When you're managing these patients on the wards, pericarditis, well, fundamentally, it's inflammation of that pericardial sac. And it presents on such a wide spectrum, often, yes, defined by pleuritic chest pain, but you also have those key physical and lab findings, the pericardial friction rub, the classic ECG changes, those elevated inflammatory markers, and sometimes a pretty significant pericardial effusion.
Right. And clinically, this isn't some rare bird. Our sources confirm it accounts for, about 5% of all ED visits for non-ischemic chest pain? That's actually quite a lot. So when we admit these patients, especially the ones meeting those high-risk criteria we'll definitely dig into, our clinical goals really have to be, both aggressive and kind of long-term oriented. We're obviously focused on short-term stability, stabilizing them now, but critically, we're also designing a management plan to optimize their long-term outcome. And a big part of that is battling recurrence.
Yeah, recurrence is a huge issue. And to really understand why it's such a formidable opponent and why our treatment choices matter so much, we probably need to start with the basic pathology, The acute inflammation, it involves increased vascular permeability, which then leads to exudation of this protein-rich fluid right into the pericardial space. And this causes mesothelial cell desquamation, and over time, it can result in that pericardial thickening, the effusion we see on echo.
But the really fascinating part, especially when you think about the idiopathic or recurrent cases, is the role of the innate immune response. The guidelines now explicitly acknowledge this, which is a big step forward. It seems like it all kind of boils down to this complex in the immune system, the NLRP3 inflammasome.
Exactly. The NLRP3 inflammasome, it's a fascinating multi-protein complex. It basically acts like an internal sensor for the cell. It gets activated in response to all sorts of danger signals, could be remnants of viral particles, could be damage-associated molecular patterns from tissue injury. And once it's activated, it doesn't just sit there. It kicks off the release of powerful pro-inflammatory cytokines. And the big one here is interleukin-1 beta, or IL-1.
Ah, IL-1, and that's basically the fuel for the fire, right?
Precisely. IL-1 is what perpetuates that whole autoinflammatory cycle. It essentially creates this self-sustaining inflammatory loop in the pericardium, and that's what makes the patient susceptible to the next flare-up. Understanding this mechanism, it's really the intellectual thread running through modern pericarditis management, because it explains not just why, say, NSAIDs work, but also why those targeted biologic therapies can be so effective in breaking the cycle when our standard methods fail.
Okay, so let's translate that foundational knowledge into the immediate clinical question for us hospitalists. How do we definitively diagnose it, and maybe more importantly, who actually needs an inpatient bed? The ACC guidelines, they offer pretty precise diagnostic criteria. They demand that pleuritic chest pain plus at least 2 of 4 specific supporting criteria.
Right, and this is where your clinical acumen really meets the lab confirmation. Those 4 criteria are the bedrock. First, you need that pericardial friction rub on auscultation. But here's the kicker for the hospitalist. The rub is notoriously transient, right? You might need to listen repeatedly, maybe to different positions, just to catch that classic high-pitched scratching sound. Missing the rub doesn't rule it out, obviously, but finding it is pretty much pathognomonic.
Okay, second, the ECG findings. Diffuse ST segment elevation and/or that PR segment depression. Clinically, I always remind trainees that the PR depression, which is often overlooked, is actually highly specific for pericarditis. It reflects atrial current injury, you see. And that helps distinguish it from things like early repolarization changes that can also cause ST elevation.
That's a great point. Third, we need evidence of systemic inflammation. So we're looking for elevated biomarkers like CRP or ESR. CRP in particular is really critical because it's quantitative. We can track it serially, see how the patient's responding to treatment. And then finally, number 4, a new or worsening pericardial effusion seen on imaging, almost always going to be a transthoracic echocardiogram, or TTE.
Okay, speaking of TTE, once the patient actually hits the ward, what's the essential initial evaluation look like? Beyond, a thorough history, listening hard for those transient rubs, getting the baseline ECG and labs, including CRP, and maybe checking for leukocytosis, TTE sounds like it's non-negotiable.
Absolutely non-negotiable. TTE is essential, not just as a diagnostic tool for confirming the effusion, but really as a risk stratification tool. We need to know if there's any hemodynamic compromise going on. Are we looking at tamponade? Or maybe less commonly in acute presentations, are there signs of underlying constrictive physiology already? The TTE really guides the rest of the workup and dictates how urgently we need to act.
And what about those more complicated or, let's say, indeterminate cases? Like a patient with recurrent symptoms where we need to assess if the myocardium is involved or figure out the extent of chronic inflammation. The sources suggest cardiac MRI, CMR is pretty valuable there.
Oh, absolutely. CMR offers really unparalleled tissue characterization. It allows us to see things like pericardial thickening and enhancement, which is a sign of active inflammation, and crucially, it can help rule out concomitant myocarditis. That finding significantly changes both management and prognosis.
Okay, so once we've confirmed the diagnosis, the next challenge, and this might be the most critical one for patient safety, is figuring out the etiology, the cause.
Yeah.
While we often default to idiopathic, presumed viral or maybe post-cardiac injury syndromes here in the Western world, that differential diagnosis can change dramatically depending on the patient's context and where they're from geographically.
This is a major area where hospitalists really have to think globally. You just cannot approach a patient with a large pericardial effusion in, say, many parts of Africa or Asia the same way you would a patient in New York or London. Tuberculosis is the undisputed champion in endemic regions. I mean, sometimes it accounts for up to 70% of cases presenting with an effusion. That's huge. And missing TB means missing a highly treatable, yet often fatal, systemic illness that very readily progresses to constriction.
Wow, 70%, that's staggering. And even within North America, we absolutely have to be thinking about malignancy, right? That requires a really focused inpatient workup. What are the common culprits? Lung, breast, hematologic cancers, they frequently metastasize to the pericardium. And then you've got systemic autoimmune diseases like lupus or rheumatoid arthritis, which might actually present first as pericarditis. And finally, let's not forget uremia, which obviously demands intensive, often immediate dialysis.
Exactly. And these non-idiopathic causes, these are the ones that are far more likely to present with those high-risk features we mentioned. They're heavily associated with poorer prognosis and much higher rates of progression to chronic complications like constriction. So, therefore, just the simple presence of a strong suspicion for one of these malignancy, TB, autoimmune disease, regardless of the effusion size, often mandates an inpatient admission and a pretty aggressive workup.
Okay, that leads us perfectly to the formal high-risk features that should trigger hospitalization. We need to be, well, pretty ruthless in triaging these patients away from outpatient management, even if their chest pain initially seems kind of benign. Where are our red lines, according to the ACC guidance? What really flags a patient for admission?
The guidance is quite clear on, I think it's 7 key features that really demand admission and close monitoring. The first is systemic symptoms suggesting something other than a simple virus. A high fever, specifically defined as greater than 38 degrees Celsius. This points away from a self-limited viral case.
Okay, high fever. What's next?
Second is the timing, the temporality of the presentation, a subacute onset. So, when symptoms develop insidiously, maybe over days or weeks rather than acutely over just a few hours, it correlates really strongly with those non-idiopathic causes we just talked about, malignancy, TB, autoimmune disease, all of which carry a poorer prognosis and definitely require extensive inpatient investigation.
Right, subacute onset is a worry. What about the effusion itself?
Third is significant anatomical or hemodynamic involvement. So this means a large effusion defined as greater than 2 centimeters or 20 millimeters on the TTE. Now, an asymptomatic large effusion might not need immediate drainage, but it certainly requires inpatient monitoring. And of course, the presence of actual cardiac tamponade is an immediate red flag requiring stabilization right away.
Makes sense. Number 4.
Fourth is the failure of initial outpatient therapy. If they're showing up at the hospital despite already being started on NSAIDs or colchicine, we need to bring them in. We have to reassess compliance, check the dose, and critically rethink the underlying etiology. Their disease is proving resistant, right?
Good point. Resistance to first-line treatment. What else?
Then we turn to the patient context, which is the 5th major factor, immunosuppression. This covers anyone who's on chronic steroids, has active HIV, or an active malignancy. These patients are highly susceptible to things like purulent pericarditis, which is a surgical emergency, or maybe neoplastic involvement of the pericardium. Their immune system just can't be trusted to clear the inflammation effectively on its own.
Okay, immunosuppression. That leaves 2 more.
The last 2 red flags relate more to iatrogenic or traumatic risks. So pericarditis following trauma or really any presentation in the context of oral anticoagulation warrants admission
And why is that specifically?
because of the immediate high risk of developing a hemorrhagic effusion. And that can lead to rapid, life-threatening tamponade. So these high-risk patients, they require sequential monitoring, checking their inflammatory markers, frequent TTEs to watch that effusion size and character.
Got it. So once admitted based on these criteria, what are the general inpatient management measures that kick in?
Well, hemodynamic monitoring is obviously paramount, especially as we start anti-inflammatory therapies that might affect their volume status. But maybe the real key to good inpatient care here is serial surveillance. We absolutely must repeat the TTE and those inflammatory markers, particularly CRP, to monitor the disease trajectory and make sure our treatment is actually working before we even think about discharge.
Okay, serial monitoring. And there's also a simple measure that often surprises patients, but the sources emphasize it quite strongly. Exercise restriction. The recommendation seems very specific. Exercise is restricted until complete clinical and laboratory remission is achieved. We're talking about restricting their maximal heart rate to less than 100 beats per minute for at least 1 month. That's quite restrictive.
It is, but it's critical. The physical stress of exercise can mechanically aggravate those inflamed pericardial layers. It increases inflammation and could potentially drive recurrence. It really is a necessary measure to ensure we don't inadvertently turn an acute episode into a chronic problem just by irritating the sensitive tissue during that initial healing phase. And this guidance needs to be explicitly given at discharge, very clearly.
Okay, absolutely crucial point about exercise restriction. Now let's get to the cornerstone of treatment, the pharmacologic therapy. Based on pretty strong evidence, the ACC recommends high-dose aspirin or high-dose NSAIDs plus colchicine for virtually every patient with acute idiopathic pericarditis.
Yes, that combination is really the power move here. Let's break it down. Looking at the high-dose anti-inflammatories first. Aspirin, usually dosed at 325 to 650 milligrams 3 times daily, is generally the preferred choice for patients who also have underlying ischemic heart disease. We want to avoid potential negative cardiovascular effects of certain NSAIDs in those folks. For others, high-dose NSAIDs like ibuprofen at 600 to 800 milligrams every 8 hours are typically used.
And the therapeutic duration is critical here, right? This seems to be where many non-hospitalists might go wrong. We can't just stop the drug when the patient feels better.
Precisely. That's a classic mistake. The NSAIDs require a slow, deliberate taper, and this taper must be strictly guided by 2 things: the clinical picture symptom resolution and the normalization of the CRP level. If you stop the NSAIDs too quickly while that CRP is still simmering, still elevated, you are practically guaranteeing a recurrence down the line.
Yeah, setting them up for failure. And a quick but non-negotiable side point on patient safety. Anyone on these high-dose NSAIDs absolutely must receive gastroprotection, right? A PPI is recommended for all patients because the risk of GI bleeding and ulceration is pretty high with these anti-inflammatory doses.
Absolutely essential. Okay, and then there's the other part of the combo, the recurrence fighter, colchicine. Its inclusion is supported by really robust, randomized controlled trial data. It clearly demonstrates its ability to significantly reduce recurrence rates and also increase the likelihood of achieving complete remission. So colchicine isn't just an adjunct, it's really essential co-therapy.
Can you just quickly detail the colchicine dosing and duration? Because I think it often causes a bit of confusion for clinicians who don't manage these patients regularly.
Sure. The dosing is weight-based. It's 0.5 to 0.6 milligrams twice daily for patients weighing over 70 kilograms with the same dose, 0.5 to 0.6 milligrams, but just once daily for those 70 kilograms or less. The duration is also pretty protocolized now. For an initial acute episode, you aim for 3 months of therapy. If this is a patient's first recurrence, however, you extend that duration to at least 6 months. And a practical caveat, always check renal and hepatic function, as colchicine does require dose adjustment if there's impairment.
Okay, 3 months for first episode, 6 months for first recurrence. Dose suggest for kidney liver issues.
Got it. Now let's pivot to maybe the most complex management territory and what I think of as the heart of the pericarditis paradox, the role of corticosteroids. We know they're potent anti-inflammatories, but their early use seems associated with some pretty disastrous long-term outcomes.
Yeah, this is where we really need to exercise maximum restraint. Corticosteroids are not first-line therapy for acute idiopathic pericarditis. Let's be clear on that. They must be strictly reserved. Reserved for patients who have demonstrably failed first-line therapy, the NSAIDs plus colchicine, or maybe they're intolerant to NSAIDs or colchicine, or there are specific indications like an underlying systemic autoimmune etiology where steroids are already part of the baseline treatment, maybe for severe SLE, or potentially in pregnancy where options are more limited.
And what exactly are the risks we're so concerned about, specifically linked to using steroids early in the first episode? The evidence here is pretty unequivocal. The early introduction of corticosteroids in that initial acute episode significantly increases the risk of recurrence later on. What happens is, by suppressing the inflammation maybe too rapidly, without eliminating the underlying trigger or really regulating that IL-1 pathway we talked about, the inflammation just rebounds aggressively once the steroid is tapered. This often leads to a more persistent, steroid-dependent or recurrent state, and this rebound flare can often be worse than the initial presentation was.
Wow. So if they absolutely must be used, let's say due to a severe autoimmune flare or true intolerance to the first-line agents, how do we manage the dose and, crucially, the taper?
Right. If you have to use them, we use the lowest effective dose possible, generally low to moderate doses like prednisone 0.2 to 0.5 milligrams per kilogram per day. And the tapering, well, it must be excruciatingly slow. I can't emphasize that enough. The taper is guided rigorously by both clinical improvement and, most importantly, the normalization of the CRP. If that CRP starts to creep up as you taper the steroid dose, you have to hold the current dose or maybe even increase it slightly before you attempt the next decrease. This trade-off, immediate relief versus the risk of long-term steroid dependence and recurrence, probably the hardest thing to manage in these patients.
Yeah, that sounds like a real balancing act. Before we move on to the targeted biologics, we should quickly touch on disease-specific management, just reinforcing that you absolutely must treat the root cause if it's not idiopathic.
Absolutely critical. If we have a diagnosis of tuberculous pericarditis, obviously antitubercular therapy is mandatory. If it's uremic pericarditis, the patient needs intensified dialysis. In these specific scenarios, the general principle of minimizing steroid exposure still holds true. Corticosteroids are typically reserved only for documented constrictive physiology developing, or maybe refractory inflammation that fails to respond to the disease-specific therapy itself.
Okay, so what happens when we're facing refractory or recurrent pericarditis, those patients whose NLRP3 cycle is just, running on overdrive, often reflected by that persistently elevated CRP despite NSAIDs and colchicine? That's when we escalate, right? This is where the targeted anti-IL-1 agents come into play.
Exactly. This is really cutting-edge management, and it stems directly from our improved understanding of the pathophysiology. Anti-IL-1 agents like anakinra or rilonacept are specifically recommended for patients exhibiting this persistent inflammatory phenotype. They act as really effective steroid-sparing options. They can achieve remission by directly blocking that key perpetuating cytokine, IL-1.
Okay, that makes sense, targeting the core mechanism. But given that these agents are significantly immunosuppressive, what are the screening diligence measures we need to take before starting them, particularly in the inpatient setting?
That's a crucial point. Because we are inhibiting a core component of the immune system, the risk of opportunistic infections definitely increases. So before initiating anti-IL-1 agents, rigorous screening for infectious contraindications is absolutely essential. This includes checking for hepatitis B and C, HIV status, and screening for latent or active TB. It's a specialized therapy for sure, and usually requires careful management, often in concert with infectious disease experts.
Right, definitely need to rule out underlying infections first. And for the absolute most extreme refractory cases, the ones that fail even the anti-IL-1 agents, the sources mentioned we might consider other systemic immunosuppressants like azathioprine or maybe even intravenous immunoglobulin, IVIG. And then I suppose for the mechanically compromised, radical pericardiectomy remains the ultimate definitive option.
It does, although it's a major surgery with significant risks. Moving now to perhaps the most time-sensitive inpatient concern, the progression of a simple effusion to cardiac tamponade. Recognizing this quickly is, well, it's the difference between an uncomplicated hospital stay and a potential code blue situation.
For sure. Clinically, a simple effusion might just present with some dyspnea, maybe nonspecific chest discomfort, or perhaps reduced heart sounds on physical exam. But when tamponade develops, that's when we can see hemodynamic collapse. We all learned Beck's triad in medical school: hypotension, jugular venous distension, JVD, and muffled heart sounds.
And while Beck's triad is classic, it's actually frequently absent in a modern hospital setting where patients are being closely monitored. The single most frequent symptom, cited in the sources, is simply dyspnea. But the critical physical finding we really need to look for and elicit is pulsus paradoxus, that drop of greater than 10 millimeters of mercury in the systolic blood pressure, specifically upon inspiration. This finding is highly indicative of ventricular interdependence, basically the heart chambers getting squeezed by the external pressure.
Okay, so look for pulses paradoxus, don't rely solely on Beck's triad, and the gold standard for confirmation remains the TTE, right? Especially because we need a rapid diagnosis for unstable patients. What specific echo findings should the hospitalist be looking for that really confirm the hemodynamic significance of the effusion, differentiating it from just a simple, large effusion that isn't causing problems yet?
Yeah, on the echo, we're looking for clear signs of impaired diastolic filling due to that external pressure from the fluid. The key findings are, first, right atrial and/or right ventricular diastolic collapse. This happens during the lowest pressure phase of the cardiac cycle, diastole, when the external pressure actually exceeds the chamber pressure, causing it to buckle inward. Second, you might see exaggerated respiratory variation in the transvalvular flow velocities across the mitral and tricuspid valves. And third, you often see a plethoric inferior vena cava, the IVC, that shows minimal collapse with inspiration. This suggests high central venous pressure because the constrained right heart just can't accommodate the venous return properly.
And it's so crucial to stress, isn't it, that hemodynamic compromised tamponade is determined more by the rate of fluid accumulation, not necessarily just the absolute volume. A small, rapidly accumulating effusion, maybe from trauma or an acute bleed, can cause life-threatening tamponade much faster than a large, chronic, slow-growing effusion that the pericardium has actually had time to stretch and accommodate over weeks or months.
That's absolutely right. Rate over volume is key. So when tamponade is confirmed by TTE, the management is urgent. Immediate echo-guided pericardiocentesis is the preferred intervention for any hemodynamically unstable patient. And a key point here, this is not a race. We must emphasize slow drainage. Rapidly removing a large amount of fluid can actually trigger something called pericardial decompression syndrome, which paradoxically can lead to ventricular failure. So slow and steady.
Slow drainage, got it. We also need to clarify the role of pericardiocentesis for purely diagnostic purposes, right? It's indicated for an effusion without tamponade only when there's a strong suspicion of those specific, high-risk, non-idiopathic causes we discussed earlier.
Precisely. If we strongly suspect bacterial infection, malignancy, or tuberculous pericarditis, we need that fluid for analysis. We need cell count, gram stain, cultures, cytology maybe, TB testing. The fluid analysis is what determines the subsequent medical therapy. But importantly, we do not tap an asymptomatic, presumed idiopathic effusion just because it's there and maybe looks large on echo. The risks generally outweigh the benefits in that situation.
Okay, tap only if suspecting infection, TB, or malignancy, not just for size. And finally, when do we get the surgeons involved? When do we call cardiothoracic surgery?
We generally reserve surgical intervention, typically a pericardial window or sometimes a full pericardiectomy for tamponade that's caused by more complex situations. Things like aortic dissection extending into the pericardium, significant trauma, or a frank purulent infection where the fluid is thick, maybe loculated, and just not easily amenable to percutaneous drainage with a needle.
Makes sense. Okay, looking longer term now, let's address prognosis, recurrence, and the risk of progression. That high rate of recurrence you mentioned earlier is exactly why we treat so aggressively up front with colchicine, right?
Exactly. After that first idiopathic or viral episode, recurrence is unfortunately quite common. Somewhere between 15% to 30% of patients will experience another flare, usually within the first 3 to 6 months after the initial event.
So who are the patients we need to monitor most closely after discharge? The ones who are at particularly high risk for recurrence or other long-term complications?
We look for several predictors that flag higher risk. Having an underlying systemic autoimmune disease is a major driver of chronic inflammation and recurrence. Female sex seems to be a risk factor as well. Also, the presence of a large effusion or actual tamponade at the initial presentation predicts higher recurrence. That worrisome subacute onset we discussed earlier is another predictor. And of course, failure of the initial NSAID therapy suggests a more resistant disease process.
Okay, those are good clinical predictors. From a surveillance perspective, is there a single strongest laboratory predictor we can track, perhaps after discharge, to gauge their risk?
Yes, that would definitely be persistently elevated CRP. Specifically, the data suggests that if the CRP level is still greater than 10 milligrams per liter after 1 full week of initial guideline-directed therapy, NSAIDs and colchicine, that patient is flagged as high risk. This finding actually carries a hazard ratio of about 2.4 for recurrence. So knowing that CRP at 1 week should profoundly influence the planned duration of their NSAID and colchicine therapy, and certainly the intensity of their follow-up plan.
Wow, CRP 10 after a week is a big warning sign. Okay, the ultimate long-term complication, and probably the most challenging to manage if it happens, is progression to constrictive pericarditis. Fortunately, for the vast majority of our patients, the ones with idiopathic or viral disease, this progression is actually quite rare, less than 2% according to the sources.
That's true. It's rare in idiopathic cases, thankfully. But the risk escalates dramatically with certain specific, more destructive etiologies. Progression to constriction occurs in a staggering one-third, about 33% of bacterial pericarditis cases, and roughly 20% of tuberculous cases end up with constriction. This stark contrast really reinforces why that etiologic workup for non-idiopathic causes is so paramount when they're admitted to the hospital.
Yeah.
We need to identify those high-risk etiologies early.
Absolutely. What about managing chronic effusions, the ones that are large but remain asymptomatic?
For those large asymptomatic chronic effusions, the management often leans towards watchful waiting, using serial TTE surveillance maybe every 6 to 12 months. But if that effusion eventually becomes symptomatic, causing dyspnea or chest discomfort, or critically, if it causes recurrent episodes of tamponade, then intervention is required. That might be repeat pericardiocentesis, or perhaps more definitively, a surgical pericardial window to prevent reaccumulation.
Okay, watchful waiting unless symptomatic or recurrent tamponade. So, wrapping things up, what's the overarching message here?
I think the overarching message is actually pretty positive. Most patients, particularly those with simple idiopathic or presumed viral pericarditis, ultimately achieve a favorable long-term course. But, and this is a big, but that favorable outcome is entirely dependent on our adherence to modern guidelines. That means rigorous risk stratification upfront, a thorough etiologic workup when indicated, and the strict use of guideline-directed therapy, especially combination NSAID-colchicine therapy, and paying close attention to those who present with high-risk features.
Yeah, this detailed deep dive really underscores the precision that's required in managing acute pericarditis effectively on the wards. Our initial diagnostic criteria are strict, and that first-line treatment cornerstone has to be high-dose NSAIDs or aspirin combined with colchicine, given for a sufficient duration, guided by symptoms and CRP.
Absolutely. And we must treat steroids as an agent of last resort for typical idiopathic cases. The clinical evidence is just overwhelming now that their early use in the initial acute episode directly links to adverse long-term outcomes. It does this by potentially exacerbating that underlying IL-1-driven inflammatory cycle and basically setting the patient up for relentless recurrence down the road.
So if we try to connect all this to the bigger picture for the hospitalist, the primary goal isn't just about making the patient feel comfortable and symptom-free today. It's also crucially about ensuring they don't return 6 months later with a frustrating recurrence, or worse, years later with disabling constriction. That necessity of balancing immediate inflammation control with the prevention of a chronic relapsing course fundamentally dictates why that cautious, stepwise approach to escalating immunosuppression, particularly regarding steroids, is so paramount. It really forces us as clinicians to constantly question if the short-term relief is worth the potential long-term risk, something important for all of us to mull over.